ERCP is technically challenging in patients with altered gastrointestinal anatomy. Recently introduced double-barrel endoscope permitted the examination of a much longer segment of a small bowel compared with a conventional endoscope, and may be used to perform ERCP in these patients. Because diagnostic and therapeutic interventions for the pancreatic system in previously operated patients by conventional endoscopes are difficult, we describe our experience of ERCP using a short DB in these patients. Because short DBE has a 2.8 mm working channel and working length of 152 cm, all conventional ERCP devices are available. That is why we used a short DBE. We thought that there were several reasons for higher success rate with a short DBE. Because of its short working length and availability of various devices, the use of a short DBE increased the success rate of reaching the papilla and blind end, and of ERCP-related interventions. Patients and methods. Between February 2006 and November 2010, we performed ERCP with the use of short DB for 157 patients in 260 procedures. The bowel reconstruction methods includes 140 Roux-en-Y total gastrectomy procedures in 88 patients, 53 broad gastrectomy procedures in 35 patients, and 55 pancreatic duodenectomy procedures in 25 patients. ERCP using a short DBE. Patients were pre-medicated with midazolam, pentacin, and buscopan on an as-needed basis. DB ERCP involved the following three major steps. The first step was to deeply insert an endoscope to the brain end. The second step was to perform contrast enhancement of the pancreatic or biliary duct. And third step was to cannulate deeply the duct and to perform endoscopic treatments. Deep incision to the blind end. For the broad gastrectomy and pancreatic duodenectomy, once the apparent loop is identified, incision into the blind end is easy. For Roux-en-Y reconstruction, the incision into the wide loop is often difficult. Therefore, the endoscope should be inserted carefully using the juggling technique, which is a basic incision method of the DBE, especially when the wide loop has a sharp angle. The endoscope is inserted while a large loop is formed, and the force is not transmitted to the endoscope end. Therefore, it's often very difficult to advance the endoscope backwards. We analyzed our experience based on the following items. 1. Success rate of DB reaching the blind end. 2. Success rate of contrast enhancement of the target bile duct in patient where the blind end was reached. 3. Success rate for treatment of pancreatic and biliary ducts in patients for which contrast enhancement of the targeted bile duct was successful. 4. Type of the treatment. Result 1. The success rate of the DBE reaching the blind end was 96.9%. We studied the matter further. The success rate of the Roux-en-Y reconstruction was 94.3%. All the cases in broad reconstruction, PD reconstruction, and the other reconstructions were successful with a success rate of 100%. Result 2. The success rate of the contrast enhancement of the targeted bile duct in patients where the blind end was reached was 1972.2%. We studied the metaphor that the success rate of root canal reconstruction was 94.7%. All the cases in blood reconstruction, PD reconstruction, and other reconstructions were successful, with a success rate of 100%. Result 3. The success rate for the treatment of the pancreatic or biliary duct in patients where contrast enhancement of the targeted bile duct was successful was 100%. Regardless of the reconstruction methods, biliary cannulation was successful in all cases. Result 4. DB-ERCP was possible in all the treatments, the same as in any conventional ERCP. The types of treatments we performed were stone extraction, endoscopic sphincterotomy, balloon dilatation of cholecystectomy, placement of a plastic and a metallic stent, etc. Summary: without saying, in order to successfully DB-ERCP, good teamwork among physicians with abundant experience in both the DBE and ERCP is important. Conclusion: as a result of our study and based on your experience, which I have demonstrated, we conclude in ERCP using a short DB is highly effective in patients with alterated gastrointestinal anatomy. Thank you.